Welcome back. You're watching the Power Breakfast Show. Now, in our first interview this morning, we want to focus on cancer, seeing as it's World Cancer Day. We want to see what are the strides we've made as a country. Are we making any strides? Let's start from there. And, share some thoughts on what needs to be done in order to get our country moving to end this scourge that kills nearly 76 people a day, as per a report that has been done in the dailies. And this morning, we're joined by Professor George Magoha. He's the chairman of the Medical Practitioners and Dentists Board, Dr. James Nikal, Member of Parliament of SEME, as well as Ms. Monica Mudene. She's a cervical cancer survivor. She'll be sharing her story and her journey with us. And if you have any questions regarding this topic, 22422 is the SMS line, or you can get us on Twitter. The hashtag is Power Breakfast. We'd love to hear from you, so get communicating with us. For now, I hand you over to Mr. Njal. Mr. Njal?
Good morning, doctors and the lady. Good morning. Good morning. Maybe we should start by stating the magnitude of the problem. So, cancer is a wide thing. There are many cancers. Maybe from your professor, you can tell us what's the magnitude of the disease. Thank you very much. Cancer, in general, is a very serious problem in this country and in the world. Looking at the female cancers, breast and cervical cancers are extremely common among our women, and with regards to male cancers, cancers of the prostate and lung are also quite common. The reason why cancer does not take a frontline place is because it is a silent condition, and most of the patients, since they are not used to either regular medical checkups as required or are ignorant of the fact that they should do so, only come when the cancers are symptomatic. And therefore the cancer load is extremely high, unlike in the developed world where they are picked up when the cancers are early. It's about time the government of the Republic of Kenya should take a serious lead in sensitizing the public about the magnitude of this disease, so that cover is provided and facilitation is provided for early diagnosis. That is the only way this can be controlled. Dr. Nikal, as Member of Parliament and also former Director of Medical Services and also a member of the Health Committee, what's your perspective about the problem?
The perspective about the problem is that the non-communicable diseases, cancer, diabetes and hypertension, are actually becoming a bigger disease burden than it was before. And in developed countries, this came when they already dealt with the problem of infectious diseases. In our case, it is coming when we haven't really dealt with and eradicated most of the infectious diseases. So we are going to have a double burden of disease as a nation. At the same time, the cancer and other non-communicable diseases are very expensive to treat, and they are going to take a lot of money, and the focus will be on it. And because of the high cost and the competition for finances with infectious diseases, the country is really going to face a major problem. And some of them are really chronic diseases, the non-communicable diseases. And cancer is on the rise, breast cancer, cervical cancer, prostate cancer, as Professor had said. So the issue is, do people have access? And many of the people who will be afflicted by this disease actually will not have access, because even those who have insurance, the moment you are diagnosed with cancer, when you go the following year, you will find that now you are excluded. So it is excluded from insurance. So those who can afford insurance soon find that they don't have insurance. Those who couldn't have insurance even at the beginning do not have access to the kind of treatment that they need. So really it's a major problem.
If insurance denied you insurance because of cancer, what is it?
We look at what Insurance in health are two types. You have what we call a social health insurance. That is the insurance that is covering everybody and covering all diseases, where you actually are looking at solidarity, so that those who are well, their money will cover those who are very sick. But the other insurance is insurance as a business, in which case we want to, the insurance people will want to have exclusions, and these exclusions are the high risk cases or cases that are known. An insurance business that does not take a risk that is already known, so they will exclude. So in terms of business principle, that may be correct, but in terms of healthcare, I've never agreed with it. But that is the reality as things stand now, unless you go into a broader insurance that covers everybody.
Does that happen all over the world? Is that on Kenya?
Well, in some countries, I think this insurance concept is in Kenya. The US took that path, but you see, they're moving away from it now. With Obamacare, they're moving away and getting to a place where everybody is insured, and all conditions are covered. In Kenya, as it is, that is not. In countries like, say, Japan, there is universal insurance and everything is covered. And unless we move to that and have universal health coverage for all people, people who need it most, like people with cancer, are the ones who are likely to suffer most.
Professor, what about you are in the medical practitioners, dentist. You are the one, you are in charge of doctors and dentists who treat those cancers. What do you think should be done so that money is available, and so that we have money, we have the hospitals, and we have the equipment?
If I may speak very freely and firmly, first of all, we'll start with the government efforts, which in my view...
And government efforts means your tax?
Yes, our taxpayers. Yes. The government efforts have got to be increased, because I'm talking from the backdrop of the fact that Kenyatta National Hospital, which is which is what I would call the hospital for this country, to date has some cobalt 60 machines. Only one of them is working. This is the old technology and does not have the linear accelerator. In fact, they are saying that, to give credit to the government, they are saying that there is a linear accelerator machine that should be launched next month. Now, for me, I don't work with will be launched next month. So there is no machine that is reasonably active and efficient at Kenyatta National Hospital. In my view, Kenyatta National Hospital should have 4 linear accelerator machines.
What are these machines?
These are the newly advanced radiotherapy machines that will treat all manner of cancers, that will reduce the load of patients going out of the country. Point number 2, when you go to the private sector, you find that the Aga Khan Hospital has 2 linear accelerator cancer treating machines, plus a brachytherapy machine. And we come to Nairobi Hospital, they also have 2 linear accelerator cancer treating machines. So does MP Shah. And then there is a Texas Cancer Center with 1 of them.
The
Texas Cancer Center is one of the privately owned cancer centers within the Nairobi metropolis. Yeah. And the point I'm trying to make is that all these privately owned cancer treating machines are only operating at about 20%. They are operating at about 20%. And I want to give credit to them, because whenever the machines at Kenyatta National Hospital are broken down, they treat patients there free of charge. If you wanted me to talk about the roadmap is to very gently ask the government to be serious, because it is a question of priority. And in my view, I don't think cancer has been prioritized enough. The government can afford 4 radiotherapy machines. We have the staff that can do the work. And so most patients know Kenyatta National Hospital. Now the question of perception where patients think that radiotherapy treatment is so expensive in the private sector is also not true. Because a session of radiotherapy at Aga Khan Hospital, for example, is only 4,500 shillings. And then you would ask yourself...
But 4,000, Professor, is not cheap.
Yeah, no,
that is.
When I finish, you will understand.
Yeah, okay.
This is against the backdrop of looking for money and going for treatment outside the country, where you have got to consider even the transport and living conditions and so on. So it is not cheap, but even for the middle class, there is a conception problem where they think that these facilities don't exist or they are too expensive, but when they actually go outside the country to get treated, they are actually not getting worth their money. And I think this point has to be made known to the people that the facilities are available. I want to say that the Medical Practitioners and Dentists Board is going to take a very firm stand by considering putting a price ceiling for treating cancer patients, like we have done in most surgical operations, for example.
Which means what?
We will sit down.
That you dictate to hospitals.
No, I will not use the word dictate. We shall engage the stakeholders, the patients' rights people, the hospitals, the government, and come out with a reasonable fee. And it will be on a range, a lower range and a higher range. So if a patient still chooses to go for treatment abroad, it will be a matter of his own choice, knowing very well that this facility is available and there is this is the range and so on and so forth.
I'm not sure whether people go there to India, for instance, because there are so many Kenyans going for breast cancer treatment and other cancers into India. Is it choice or is it?
First of all, let me just put you.
They don't have. They not. Recently, we sent a relative of mine to India for treatment of a back problem. She was advised that place where you get spent about $1 million. Is it because of ignorance or because India is better?
Let me first of all tell you that, first of all, the principles of treatment of cancer are very simple. You identify the cancer early and you treat and cure. Take, for example, breast cancer. If people are sensitized on how to examine their breasts and they are able to diagnose the breast cancer early, in what we call stage 1 or 2, at that stage you can actually cure the breast cancer. But most of the times the cancers come when the cancer has already spread, and it does not matter where you go. The issue that we shall be dealing with is quality of life. And most of the patients who go to the so-called India, for example, are cancers which definitely have spread, and that the kind of treatment they get there does not necessarily cure them, but improves their quality of life. That treatment is available here in this country. It is a question of the perception of our people and their mindset, and something has to be done to change that.
Monica Muthini, you have a patient, you have had cancer. Mm-hmm. Can you tell us your story and how you got treated and where?
Yes, my name is Monica Muthini, cancer survivor. I've gone through 2 cancers, cancer of the cervix and cancer of the breast. The first cancer was cancer of the cervix. That was 1993. Today is my 23rd year since I was diagnosed with cancer of the breast, of the cervix. And it was not easy because if you may all know, that time 1993 cancer was not known like today. And when I was told that I had cancer of the cervix, what I saw was just death. I thought my life has come to an end. And cancer of the cervix, I can say, is one of the killer diseases. Reason being the nature of the cancer itself. Because cancer of the cervix, the symptoms are discharge. And a discharge, most ladies, okay, a healthy lady must have a healthy discharge. But mine was becoming creamy and it had a funny smell. And when a lady has to go out and say that, look, I am suffering from this, most of us shy away from that. Reason being, they ask themselves, how will people look at me? People will think that I have gone out with many men, or, you know, and I normally say, every time I go out to reach out to people to talk about cancer, I normally say that if you shy away from your body or a disease, then you are shying away from your life. And that is why you find most ladies are dying of cancer of the cervix, because by the time they come out, it's already too late, because they have been scared of what will people say.
Where were you treated?
At Aga Khan Hospital by Professor Juang, and he's not the one who diagnosed my disease. It was diagnosed by a Professor Dr. Kiwul, who is late today. May his soul rest in peace. And when he diagnosed the disease, he was not able to treat me because I felt the charges were too much. And he told me, because I'm not able to assist you, I'll send you to a friend of mine who works at Kenyatta, that was Professor Juang, and see how he can help you to get admission at Kenyatta. So when he sent me there, Professor told me that he cannot encourage me to go to Kenyatta because of the way the facility is, that Monica, you'll go in with one disease and then you come out with so many diseases, you know. So at the end of the day, I managed to raise money through my family, and I was admitted and operated on at Aga Khan Hospital by Professor Juang. Yes.
Then when breast cancer?
And then
was it related, or that's a different problem?
That is the question I've asked my doctors. They are telling me they had no connection. But that was 1993 when I had the cancer of the cervix, and when I was treated after 2 years of observation and checkups by Professor Juang, he gave me a clean bill of health, and I moved on with life, and I forgot about cancer. Then 2013, same month, 20 years exactly down the line, I felt a pain under my right breast. And I took some painkillers for 3 days, and the pain was not going. So I went to hospital, Aga Khan again. I was sent for mammogram. When the mammogram was done, the doctor told me that the right breast, which was paining me, there is nothing. But on the left, which was not paining, there is something which has been seen. So he sent me to a specialist. I was sent to Professor Wasike, test, biopsy, and there was some fluid accumulating somewhere, because we are normally told a lady should feel for a lump. Mine was not a lump, it was a fluid which was accumulating somewhere. And when the biopsy was done, I was told that I have cancer of the breast, and I was operated on. And I thank God, because both cancers have been cancer stage 1. So I was treated on, operated on, and I am okay.
The message here is that you do test before it's too late. Is that the message?
Exactly.
The early diagnosis.
Yes.
Yeah, maybe if I can come in there.
Yeah.
We have to have, as a nation, a broader look at the issue of cancer. And picking from where they are said, cancers are expensive to treat, and sometimes you just improve the quality of life if it is late. So we need to start with the screening programs, so that, one, you want to catch them as early as possible, when first of all, they are easy to treat for the sake of the patients. Two, they are cheap to treat, so that we have less money spent on cancer. And so we need to have an early screening program. And let's say, like cancer of the cervix, we can have just visual inspection, just looking in the eyes, which can be actually done at a health center, so that it will cover a large number of people. And if you have a program for that, they will be picked early, and some of the treatment can be done even in some health centers at that stage with very good results. Cheap and got early, less money spent, the patients has a better chance.
Like for the center, who will do that?
Oh, with training, the nurses can actually be trained to look at the cervix, and like use of Lugol's iodine or some other chemicals. By looking at it, they'll see that this cervix is not healthy. Then they can do an early biopsy, and when the report comes back, some of them can actually be treated at that stage. If you look at the breast cancer, again, people should be aware, like in her case she was aware, and do the physical examination. Although in her case it was fluid and therefore could not be felt as a mass, in many cases the mass will be felt early, and sometimes they are felt and ignored. So if that is done early, that is possible. And then you can do a mammography. There is a machine which can actually be used even in the district hospitals, as low down as the district hospitals. So people can have regular checkup. Prostate cancer, for example, there are tests that can be done in the blood. It's a little more expensive. But if these are done early, and you do it as a program run by the ministry with a well laid out program covering all the regions, because you don't want to a stage where you want people to come to Nairobi for the linear accelerators and the Cobalt 60s and so on. That is late and expensive. So if that is done, we will reduce the burden of disease both to the patient and to the taxpayer.
But you are saying that you use the direct from medical services.
And exactly that's what I did. If you now go into some of our health centers, they are actually doing what we are calling visual inspection for cancer of the cervix. The mammograms, actually they are trying to put them out. There was a program for that, a little more expensive, and they are not there. What we need is actually continuity. There are many programs we started. In fact, if I go to NCDC in general, by the year 2004-5, I'd actually indicated we needed a whole department of non-communicable diseases. It has improved a bit, but probably not as much as I would. Coming back, if we have that program, then it will be less expensive. Then when we come to the late stage, again we will have to put more money in it, and so that all people don't have to come to Nairobi. We should pick centers. And going back to when Director of Medical Services, we actually started, it didn't pick up well, but we wanted a center in Kisumu as well. Now with the county governments, we could actually pick some referral facilities at various counties and start, even if in a small way, places where people can be treated. And then we have to say, how is all this thing going to be paid for? Definitely, the government has to put more money. As I was saying earlier, we have to start looking as a broader insurance cover. I'm happy. I've noticed that today CO2 has agreed with NHIF that they will now pay pay premiums according to the salaries that people get. Notwithstanding the problems we know we have with the management of the funds, and we must improve that, then we have that broad insurance that can cover for many people. And then the government putting more money so that there is a general cover. So the approach will be cancer programs, early screening, improving access to all people, probably through insurance, and having in various parts of the country centers that can actually treat people. Because even if you come to Kenyatta, even if the systems are working, the waiting list will be too long. If you go to Aga Khan and other places in Nairobi, again, the cost may not look expensive at say 4,000, 5,000, but there are people in this country that they may not be able to raise that even for a whole year. So we must have a broad outlook for that. So screening, lifestyle, financing, improving access to all people.
What do you mean by lifestyle? Are you saying that it's the lifestyle that will cause me?
You must realize that one of the reasons we have cancers is that our lifestyle has changed, the diet we take have changed. There is some association that is known, although it's not 100% foolproof. But if we take cautions on what we are told, eat like this, have exercise, healthy diet, exercises, your general well-being will improve. Maybe with cancer it will not be as important as it is with the other non-communicable diseases I was talking about, but the general burden of non-communicable diseases must be taken together with cancer. Otherwise we will start putting money in compartments, and we will not get the synergistic overall effects that we would have to have in the management of cancer and those other diseases.
Professor, what do you have to say about that?
Lifestyle, as my colleague has said, is significant. If you take cervical cancer, for example, the kind of lifestyle does not only mean what you eat, it also means how you deal with your social life. So if you have multiple partners, there are studies that have shown that women with multiple partners have more cervical cancer. I want to pick it from the point of view of government's attempts to state that cancer is important. I think the government has started getting equipment for the counties. The important thing here is not to say, well, every county government will have a cancer machine. I think what we should be doing is, if we take the former provinces, even if we start from there and get 2 good machines for every province, and they are in working condition, and they also invest in human capacity, that would get some results. Because the ordinary Kenyan, first of all, goes to a government facility. They have no capacity to go to the private sector. So the second thing is that the government makes the laws, and there is no reason why insurance companies should be allowed to operate in this country when they say you cannot be insured for cancer. That is hogwash. And I think the government should take a firm line to ensure that if you have insured yourself comprehensively, if you have cancer, it should also be taken care of. It's not a question of just making money. It can't be a question of the bottom line. So there are things which we are allowing to go on in this country which should be addressed very quickly. For example, if I have a policy and I have cancer, perhaps it would be reasonable to say the premium should go up, but they must and they shall cover. So I think in order to manage this, I agree with most of the things that Nikal has said, but there has also to be a change in mindset of our people. For example, I am a urologist, basically a urological oncologist, and you find that most...
What does that mean, urological oncologist?
My area of specialty is prostate cancer. The point I want to make is that when an old African man has problems of peeing, he does not want to talk about it. He thinks it is a taboo because it might also be related to sexual function. As a result, most patients who have advanced prostate cancer in this country come late, and they only come when they cannot pass urine. When now the urine cannot come out, you know, if the pain is too much and you must talk about it. So there must be that change in attitude, removing the culture barrier. I suspect that even for cervical cancer, it takes very courageous people like my colleague who has just spoken there. Otherwise, people will keep the symptoms until it is actually too late, and you really cannot do anything. And by that time, really, it doesn't matter what you have to do. I want to add before I stop that there are many Kenyans who have capacity to treat cancer, and since they did not come out on time, and they have been diagnosed and they have been told, well, this is terminal cancer, they still insist on going to be treated abroad. That mindset must also change, because you don't send somebody abroad to get terminal care, which is available in this country at this stage, because terminal care is terminal care.
Terminal care means what? You go home?
No, it means the quality of life that you are given. For example, if there is too much pain, you are given painkillers, you are given continuous counseling, you are given adequate foods, and any other conditions that may be associated with the cancer, like infection, are treated, and you live your life. It is the quality of life that you want, as good as possible. Finally, even in the United Kingdom, there is a waiting list for cancer patients. So we are not going to say, we are not challenging our government to say, well, there should be no waiting list for cancer patients. There shall always be one. The question is, it should not be too long. Because if you are going to the National Health Service in the UK, there is a list. There's a waiting list. You cannot possibly have a situation where when you have cancer, you walk in and you are treated, and then there's nothing else left.
How do we encourage Kenyans to have those early checks? Because people are caring about bread and butter. No, if I'm fine, why should I go to hospital? Why would I want to spend my money being looked to look for something which is not there?
Let me take on that. We all know. Let me start by saying, when somebody gets cancer, the impression that they get and the perception is that you get cancer, you are going to die. We should start from the point that we are all going to die. So whatever happens, we are all going to die. It's just a matter of when. However, we must know that if we look for anything early and deal with it early, and we make that part of our lifestyle, then it is important. If you are well, it does not mean that you will always be well, but the disease will start sometime, and it is you can't tell when it is starting if you're waiting to have feelings, symptoms in your body. Often that is late. We have a lifestyle where you know that you get regularly checked, and then those can be picked. We can have government programs, and as I told you, have had before, where if you go for other things that people go to hospitals regularly, then you are checked. Like the mothers who go to antenatal clinics, the mothers who go to family planning clinics, it will not just be restricted to that. They should also start checking, are there possible cancers, and you put it in the program. We should have, say, adolescent health that actually tell young people that you must get to the habit of getting regularly checked. And if these programs are available at government hospitals that are accessible, I think it is possible, it can be done. We have managed to do that with children. Every mother knows that when you have a child from day one, they'll all go regularly to the clinics. They are not sick, but they are going to get vaccinations, they are going to check if there is something wrong. We really have to develop a program of healthy people also getting to be checked. Right now, the programs for healthy people going to be checked are actually just in private facilities. My view is that we really need to get these programs even where they're accessible in public facilities. But now, some of these may look like idealistic, but if you do not have a dream as a country on where you want to get with any program such as health, you will never get there. So we really have to start and put them in. In 1977, when I qualified, measles was killing children like flies. Now, polio was a big problem. But when now programs were put in place, and children know that, the mothers know that children must be taken in. Now, these are diseases that we are almost on the verge of eradicating them. We must therefore now start saying, okay, with this non-communicable disease, are we going to have programs that are going to look at people, even if they're healthy, at regular intervals, so that they get checked and they're educated, so that they also feel I should be checked? I'm sure people like you and me and my friend Professor here, we actually say at least once every year, I want to be checked. It is something that we have done. We must have the same for everybody in the country.
Sorry, if I may just add something on that. When it comes to cancer, I would want to suggest that if this program can be introduced in schools, because I remember in 1993 when I was in hospital, there's a girl who was 19 years and she had just cleared her Form 4 and she lost her uterus. Why? Because of cervical cancer. So maybe when we talk about cancer, maybe ladies, if I may talk about the ladies, they think that until I'm a grown woman, that's when I need to be aggressive about knowing my status when it comes to my health, with cancer, breast, or cancer of the cervical. So my suggestion would be if it can be introduced as a program from school, because when a girl clears from school, she has already known that there's a killer disease, a silent one called cancer. So my suggestion is if it can also be introduced in schools.
The ideal that the doctor was talking about here, programs, but now health has been devolved, and the status of our hospitals now with the counties. what I hear is it's worse than before.
Before
devolution. Yeah, before we talk about that. Yeah.
Before I comment, I wanted to say that I agree with Dr. Nyikal in most of what he has said, but we cannot and shall not leave this sensitization only to government. It must be done by the doctors and other health professional groups like the Kenya Medical Association, the Medical Practitioners and Dentists Board, the Nursing Council of Kenya, and so on. It has to be a joint effort so that our people are sensitized at every stage. If it just becomes a government rollout, people will take it as any political issue. So going beyond that, it should be considered that the professional bodies, even like the one that I lead, are extremely significant. If I may comment, comment very boldly, and these are my personal thoughts about whether or not devolving health has helped. I want it to be on record that, as far as I'm concerned, the principle of devolution is noble, and I think the politicians who put it forward were right in doing so. But what I see now is like there's a power game between the central government and the governors, to the extent that, first of all, with regards to the human resource capacity of doctors in the counties, the doctors have been relegated in the counties to a level which is not professionally acceptable to me as a person. First of all, the guiding principles of recruitment have become tribal in capital letters, and it is not acceptable. You find where a qualified medical superintendent is in charge of a hospital, say for example in the coast, and he doesn't come from there. What devolution has done is to ensure that they look for a young doctor who maybe was trained by this superintendent and puts him in charge of the hospital. Now I don't have to tell you what you think is going to happen when that is happening. That has got to be corrected, and the central government has a duty. It has a duty to ensure that health services are given to our people. It is not just enough to transfer money to the governors. There are some governors, if I talk about Ongwae of Kisii, for example, who has eyeballed health. He has employed people, he has put money in health, and if you go to Kisii, to the hospitals in Kisii, you will find them working. What about other governors? So this is a headache, and I would want my brother, the politician, to tell us what he thinks about it. But for me, I really feel that the central government is like abandoning the people, and it has to take the lead role once again.
Let me start by agreeing with my colleague Professor and Monica in the context of programs that detect cancers early. I agree with her that it must start in schools. Not because you are going to pick a lot of cancer in schools, but that is where we form our habits regarding even our health. So when we come out of school knowing that there are certain things we should check regularly, that's useful. Again, I agree that when I say government programs, I don't mean just the Ministry of Health, whether at the county or national level, but when you talk of a government, in my view, the government includes everybody plus the private sector. This is all part of the nation, so that everybody must be involved in that program. Now, when we come to the county, the county governments and devolution of health, yes. I want to put an analogy. It is like a pregnancy. The baby inside is precious, and everybody knows the baby is good, and you have no doubt about that. That's what devolution is. However, how you deliver that baby can actually make the baby die, or the baby will come out deformed. So let me start by saying that devolution is something, in my mind, we cannot go back on, because it will definitely, and in some cases, like my colleague has indicated, improved services, access, being near to the people. What we really need to do, and this is both to the national government and to the county government, we are moving from one system to another. We must sit down and say, this is how things were done when we were in the centralized system. To move from that to now a devolved system is not something you wake up in the evening and say, tomorrow we are done. It can't happen. There are systems, the human resource systems. People are recruited, people are trained, people are retirement benefits. Now, if they are moving from the national government to the county government, people have to sit down and agree that is how it is going to be done. There were ways of procurement of drugs, there were quality issues. People have to sit down. If now this we are moving, do we move it at once, or are we going to have a system where we face it off, where initially there's a lot of support from the capacity of the central government to the county government? And the Constitution has actually put that in place. To begin with, there was the Transition to Devolved Government Act, which created the Transition Authority. In my mind, we did not use that act as a country properly, and the Transition Authority, for one reason or another, did not act. And there I will actually blame the national government. It's still the guiding principle that should have worked, and things should have been staged and done properly. Even after now we are arguing whether the Transition Authority should go or is still there. I think now it's going to stay for another 2 years. There is another provision, the Intergovernmental Relations Act, which has provided for the Intergovernmental Relations Secretariat, a secretariat which in my mind up to now has not been properly formed. This is the secretariat that should sit down in regard to health, and any other say, okay, in the health sector, how are we going to deal with the question of human resource? And now we have a health act which is coming through Parliament. In our committee we have to sit down with the governors and just say we have to put a provision in this act that makes it possible for the national government, the county government, and even Parliament, both Senate and the National Assembly, to sit down and work out how are we going to progress from one stage to the other. The national government has a mandate to set standards and to give policies. And that is why you will find that Governor Ongwae will probably do very well in Kisii, and other governors do very well, because we are leaving it to the chances of a person who knows or has good advisors. But if we have policies at the national level, and then we have standards set at the national level, then even in a devolved system, each governor will know this is how we do it. The problem I have now, and what looks like a fight between the county government and the national government, is just lack of realization on both sides that there is a difference between enforcing policies and standards and overloading it on somebody. What we are seeing to see with the county government, their feeling of independence is so strong that it is becoming difficult to set standards and monitor adherence to policy. But I think with time we will get, and you don't only see it in health, you are seeing it in roads, you are seeing it in agriculture, you are seeing it in water. It is the same principle. So I think we still have not lost all as a nation. We have not lost. In fact, things have improved a bit. And this I will tell the government that system of intergovernmental relations must be strengthened. The policy and standard function of the national government must be enforced. And enforcing that does not mean that the national government is taking over from the county government. To me, that is the way I think we should. If we do that, then we improve access to health. If we improve access to health, it will improve access to all forms of health problems that people have, whether it is cancer, whether it is infectious diseases, whether it is HIV. But today we are talking about cancer. In fact, if the system is not working, then it is cancer and these chronic diseases that actually become a major problem and see people suffer more. Because curable infectious diseases, people can struggle for even borrow money, treat themselves, and they're well. But with cancer, you've had it. If it's late, you are going to have treatment for a long time, and eventually you will need what we are calling terminal care, As I said, everybody will die, but when it reaches the time of dying, you should die in dignity and, if possible, in comfort.
There is a doctor from Kisumu, Dr. Onada. He says lifestyle contributes to cancer incidences, but lack of pathologists to improve diagnosis is worse. Lack of functional machines for histochemistry, I think that's what, and blood biochemistry. Hurts early diagnosis in hospitals. What do you say to that, doctor?
The doctor is quite correct, and I go back to my point which my brother has not addressed. Devolution did not mean you balkanize tribally. That thing has to be addressed, because every county except Nairobi is employing their tribes people. I, as a cancer specialist, if you take me to Siaya now, you will be wasting a national resource. I am more useful at the center. And therefore, when the county governments are looking for the human resource, they should look for capability to perform the job, not whether you come from Nyeri or Siaya or Kiambu. That is happening, and it has to be addressed. Because then you start from the point of view of having non-qualified people. Because if you distribute like that, then you will not get qualified people. And maybe as a politician, he doesn't want to go there. But me, I will say it.
I'll go there.
Secondly, it is true that once the human resource capacity is addressed, and that has to be addressed by the governors, because they seem to be politicizing the issue and saying, oh, this and this. You can't get only Jaluos from Homa Bay who are specialists to go and work in Homa Bay Hospital. It will be stupid. It has to stop. Then the government, and we must give it credit here, the government has a system now where it is taking equipment to the counties. What should be done perhaps is for the counties to consult further with the government in terms of providing the equipment that they should take there. That doctor has addressed the issue of specialists. The government now must invest, and I'm talking about the county governments also. They must invest on identifying the qualified and retaining them. Because if you want an expert to go and work in Siaya, for example, and you use the standard government guidelines to recruit, you will not get. You must put some honey on the side to attract and retain. And the reason is because we don't have adequate numbers of specialists in the country. I don't know if you want to...
let me say, I addressed it, but maybe as a politician, you probably don't get my meaning quickly.
Yeah.
But the issue is standards and policy. If we have standards, and you say for the treatment of cancer, the following shall apply. In terms of human resource, we will need people of this qualification. Now, if that is reinforced, then of course it will be clear that you will try a tribe, but you will reach a situation where tribe will not work because the qualification you are looking for is not the tribe. The issue of tribalism and corruption are two issues that probably we need a whole time on. But if the national government put standards, put policy, and that is on human resource as well. In fact, I'm saying in the Health Act that we are doing now, we are actually putting in a part to deal with how do we share and redistribute human resource in the health sector, so that some places will have national referrals, and we have them, and in the counties, the county what used to be level 5, you will also have some level of a specialist. Then that will work, but they must work with the known standard at the standard level. And my colleague here, actually, if that were to work, when it comes to the Ministry of Health, in fact it will fall on the Medical Practitioner Dentist Board to ensure that the standards are actually adhered to. And when you put standards, it will throw away things like tribalism. So that whether you are employed in Muranga or you are employed in Busia, if you are a doctor of certain specialty, the conditions under which you work will be exactly the same. If we want to say we want to put it to competition, then of course we'll have a big problem. There are areas of the human in human life, like health, where certain niceties have to be removed, and we just go by facts. We want technical competence of this level at this service for people to get care. We don't want people coming all the way from Busia to look for treatment for cancer in Nairobi. They should probably get somewhere in Eldoret or in Kisumu. Those centers must be developed. And I agree with him that as of now, the standards and the relationship between the county and the national government is such that some problems are coming that need not be there, and people are suffering. So in terms of the equipment that the doctor has indicated, you know, when you say standards and systems, equipment, human resource, drugs that are used, all these are part of standards. So that if you are looking at national government level and you are looking at county government level and you are looking at operations, then those are the things you put in place, and it can be done. I will agree with him that sometimes the governors tend to see the powers struggle more than having eyes on the prize, and the prize is the health of the people and access, and particularly those who have diseases that are hard to manage, such as cancer.
Are there some cancers which cannot be treated here? Like a lot of people get leukemia, or the children mainly. This is a question being asked by a lot of people here, that they have leukemia. They need to take their children for blood transfusion, whatever blood change. South Africa, India.
First of all, there are cancers which are completely curable now, like cancer of the testes and so on. Yes, there may be a few cancers that are not treatable here, but the majority of the cancers, you may find a type of leukemia that requires urgent bone marrow transplant. That type of cancer perhaps is better treated elsewhere. And if the doctors were working,
why not here?
If the bone marrow transplant is not quite developed in our country as we stand now, and the load in that type of cancer is reasonable for a doctor to refer the patient to his colleagues outside the country for treatment. So there are cancers. It is the principle. There are cancers, but the bandwagon of everybody being channeled out is what I'm against, because even in the private sector, you have to weigh how much it would have cost you to get treatment in the comfort of your family, rather than going to India, for example, where you are in a hotel and going from that hotel with your family and perhaps even dying there, because like I've told you, there are several aims of treating cancer. One is cure, one is just tumor control and management of quality, improvement of quality of life. So there are cancers, and I cannot give you a full list, but leukemia is a good one, where you may find that in order to save the person, you require the person to go and get marrow transplant elsewhere. That is the answer that I could give.
Let me talk about treatment abroad, because I touched on it when I was Director of Medical Services. Again, I may resound repetitive. You cannot run a country without systems, without standards, without policy. Even who is going to be treated outside, there has to be somebody who says this person is going to benefit from the treatment. The situation we have now is such that you find patients making arrangements with some middlemen abroad in India somewhere.
It has become a medical tourism.
Exactly.
Medical tourism.
Exactly.
And the people practicing is that they're not doctors.
In my view, yes. That's what I'm saying. There's some middlemen who are not doctors who say, I know where cancer is being treated well. And they make arrangement with the patient, and then the doctor just becomes a transfer, and some doctors may then condescend and start to be part of the system. My view is that we have to, even if people have to go outside, if it was left to the doctor who is handling the patient, working with the patients, to say, have we reached a stage where we cannot get this treatment? Are we going to look for a bone marrow transplant? It's this doctor who should consult with the other doctor. And I would put a suggestion to my friend here, because he's deep in regulation and standards, that we really need, I tried with the kidney transplant and dialysis and so on, when I was director of medical services, to put up a system where before somebody goes abroad, actually you have either a team of doctors at various places who will look at this condition, satisfy themselves and the patient that where the patient is going, they are actually going to benefit. Because right now I don't think we have data which is showing how many people amongst the people who go out, how many actually improve and get better, how many actually die and don't benefit, and how many, if were treated here, would have actually had the same outcome. That is not there because it has been left to the patient, their doctor, a middleman, and their doctor abroad. So that system should be looked at. Then we have to look at, and again I will talk to my friend here, that we may need to have a fee schedule scheme where, say, insurances, the government, and the medical profession, the medical Kenya Medical Association, medical practitioners and dentist board actually sit and say, what are the fee guidelines for treatment in the private sector? Because I don't understand why you will go, two people will fly to India, they will both stay in hotels, they get treatment, they fly back, and this thing is still cheaper than if you're treated in Kenya. We have to say what is going on there. So we need to have a fee schedule. This is an idea we can put in place. I know it has been started. Involve the government, involve the private sector, get patient stakeholder, so that once every 2 years we can look at this scheme and make things accessible.
Final word before we close, because we're running out of time.
Yes. This issue of people doing business with the cancer patients, it really pains us, the cancer people, because when you are diagnosed with cancer, one thing, you're confused, you are not able to think straight, so you are kind of desperate. And we even find where we meet a support group, women, people come with supplements, take this, so it is kind of another business, and it is so wrong. So I don't know what the government can do about this, so that cancer patients can be protected from these people who are money-minded, not to look after our health, but they just want to make money. My final word is just to say that, as the doctor said, that the government, we feel the cancer patients, government is not doing enough. So my urge to the government is just to request if they can invest more money on cancer.
Right now, before what would you like to say about?
I would want to say that this problem cannot and shall not be left only to the government. It requires everybody, all the organizations like ours and the Kenya Medical Association, and even the general public. Everybody must take part, because part of the problem is created by people who do not want to change their mindset. So as we encourage government to invest more on cancer treatment, we want also to encourage our groups to sensitize patients about what is available, because most of the cancers are treatable when diagnosed early enough, and the capacity at that level is there. Surgical operations would treat and not necessarily to be followed by radiotherapy, which is still a challenge. So I think sensitization will form a major part in moving forward in this area.
Thank you very much, Doctor. Thank you very much, Monica. Viewers, now you know the solution to the problem is early diagnosis. Be tested at least regularly every year.